Welcome. Welcome to Hope Rising Clinic's virtual discussion. Hope Rising Clinic, you'll hear a lot about today, but the real reason we're here today is to talk about prenatal substance exposure and what that means. And it's some research and some family stories, and I'll tell you a little bit about what we do at Hope Rising Clinic. So we're really excited to have you all here today. Thank you so much. Just a couple housekeeping items before we get started. If you could please keep your microphone muted, unless you are the speaker, we would much appreciate it. If you have questions, please drop them into the Q&A, and we will leave some time at the end to go over as many questions as we can get to. And we are recording the discussion, and that will be made available afterwards. So it is my honor to introduce to you Dr. Julie Bledsoe. Dr. Bledsoe is a pediatrician and a professor at the University of Washington who has more than 30 years of experience in advancing understanding for care of children and families impacted by prenatal substance exposure. So with that, Dr. Julie Bledsoe, I will hand it over to you.
Great. Thank you so much, Ryan. And I'm really pleased to be here. I have to say that this is a subject I feel very passionately about. I also have tremendous respect for Wonderland and the services they provide in a much needed area. So my job today is to sort of do a little presentation about sort of the scope of the problem of prenatal substance exposure. I'll be a little more specific about the effects that we see on kids, depending on what they've been exposed to, and talk a little bit about the developmental needs of these kids. So I think Ashley's going to be starting my slideshow. All right. So again, I'm going to talk about prenatal substance exposure and its impact on children. Next slide. So how big of a problem is this? And we know that even before the pandemic, pre-pandemic, we were seeing a pretty marked increase in drug, alcohol use, and or both. And it was really largely fueled by, not yet, back to the older slide, back to the back slide, perfect. And this was largely fueled by the opioid crisis. During the pandemic years, we even saw an increase in rates of substance use, increased across the United States in many age groups. And part of that was Americans sort of turning to drugs or alcohol to cope with the big changes and the downturn in the economy. In more recent years, we know that researchers estimate that about 450,000 children are born in the United States with prenatal alcohol substance exposure of one sort or another. So really a pretty significant issue for children in the United States. Next slide. I want to put this a little bit in perspective because there are a lot of people don't realize how common this is. When we think about, from census data, there about 10,000 kids plus or minus born in the United States every single day. And a lot of other disabilities get a fair amount of press. 2 of these babies will be born with muscular dystrophy. 3 will be born with HIV infection. 7 will be born with something called spina bifida. 8 of these babies are born with Down syndrome. 100 of these babies are born with fetal alcohol spectrum disorder. 20 of those have the full syndrome. And 300 of these babies will be born with prenatal drug exposure. So the magnitude of this issue compared to other birth defects in this country is really profound. Next slide. What do we know about prenatal substance exposure and disabilities for children? Is we know that alcohol is still known to be the most damaging to the developing fetus. I'll talk a little bit specifically about that. Other drugs, methamphetamine, opiates, tobacco, marijuana, all can cause learning disabilities. Next slide. Talk a little bit about alcohol exposure. This is sort of an old Soviet propaganda poster about drinking during pregnancy. But we know that alcohol is what we call in medicine a teratogen. It is a poison to the developing brain. We know that the dose of alcohol used during pregnancy is important. The timing of that use is important, with the first trimester being the most damaging to the developing fetus. We know that pattern of use, daily heavy drinking, of course, the most damaging, but binge drinking can have a really profound impact on the brain as well. And then we also know that there are certain fetuses that seem to be more susceptible to alcohol exposure than others. And we even have at the University of Washington an interesting twin study where fraternal twins bathed in the same alcohol can have different diagnoses. Next slide, please. We know that full-blown fetal alcohol syndrome is the tip of the iceberg. We do have a marker for fetal alcohol syndrome. That's the face of fetal alcohol syndrome, which I'll show you in a minute. But we don't have a marker for exposure. You can have a completely normal face, but a profound disability because of alcohol exposure in the utero. And that is because the facial features are formed in a very small window of time in the fetus. That it's like days 19 to 21. So if a birth mother misses those days with drinking, or if there is binge drinking, then we know that you can certainly have brain damage, but not the marker of the face. We also know it's often difficult, if not impossible, to sort out other factors like other prenatal substance exposure, which I'll talk to. Next slide, please. So down below, you'll see the face of fetal alcohol syndrome, very smooth upper lip. Very thin upper lip, a very smooth crease between the nose and upper lip. And the third feature is actually a small width of the eye opening. And we actually measure the eye with photographs with computer pixels, which is kind of interesting. And people often say, well, the girl below doesn't look like she has small eyes. Children with fetal alcohol syndrome have eye sizes that are often more than 2 standard deviations below the normal range. But this young lady has a very small brain, and so her eyes relative to her brain size look like they can be large. But this is sort of the classic face of fetal alcohol syndrome. Next slide, please. What about other exposures? Of course, the most research has been done on alcohol exposure, and you can see there that down the board from fetal growth down to long-term effects on growth, behavior, cognition, language, and achievement, we know that alcohol has a very strong effect. Interestingly, smoking, nicotine exposure also has some effects. Cannabis use is under study. We really, since the legalization of marijuana in multiple states, we really are just starting to see the research that looks at marijuana exposure and long-term outcome for children for behavior, cognition, language, and achievement. So that's really still underway. Opiates, interestingly enough, compared to alcohol, it's always weird to say that if you're a fetus, you'd rather be exposed to heroin than alcohol, but it's absolutely true. We know that opiates do have an effect, particularly on neurobehavior, but the magnitude of the effect is not as strong as it is for alcohol. We know that cocaine has some effects, but interestingly enough, when there was a lot of alarm in the late 1970s and 80s with crack babies, we know that a lot of those studies did not show a profound impact on the kids. And there are even, some really wonderful documentaries about crack babies who were identified as being very damaged when indeed, actually, many of them had completely normal development long-term. And then methamphetamines, which, have been on the rise for the past decade. Some of that research is still pending. Again, it's always amazing to see the impact on the user. The person who's using is more profound in many ways than on the fetus. But we certainly are seeing very concerning emerging effects on the neurodevelopment of kids exposed to meth, particularly heavy meth during pregnancy. You can also see that, often alcohol and drug use go hand in hand. And so we can see a child that has multiple exposures and can see the impact compounded by the use of these substances. Next slide. So what are the disabilities caused by prenatal alcohol and drug exposure? And they really vary from mild to severe. My predecessor in the fetal alcohol syndrome clinic always talked about the brain. As a circuit board. We're all born with a particular circuit board. And depending on what substance was used and when in pregnancy, different wires will be clipped for different kids. So I will say one of the challenges of these kids is, yes, we do see certain patterns of disability in kids, but every child is a little bit different. And it can be confusing because sometimes we see kids with, real strengths in development next to real weaknesses. So really tailoring the early interventions for kids can be important. We know that newborn withdrawal is an important issue, but is really only the tip of the icebergs. While many kids early in life can have developmental delays and need support for language and occupational therapy and physical therapy, we really know that the part of the brain most affected by substances is the part of our brain that governs higher order thinking, sustained focused attention, complex problem solving. And those things we really can't, mood regulation, certainly very important, but a lot of those things we can't identify until a little bit later in life. We don't expect infants to do a lot of complex problem solving or have a lot of language, but we certainly see these disabilities sort of evolve. They don't evolve over time, but they show up at different periods in life. And we also know that disabilities that are caused by prenatal alcohol and drug exposure can really be lifelong. And so the challenge is really to get in there early, to provide support for kids so that they can reach their best potential. Next slide. The brain injuries in these kids really have gone undiagnosed and unserved. Interestingly, in the medical field, we have some strong feelings about it, particularly, not that we're all in competition with autism, but autism has received a lot of funding, and prenatal substance exposure has not received a lot of funding. Many of us believe that it is because the population that is affected by prenatal substance exposure is often a population that is underserved in many other ways. But we do know that there's been a real lack of support and services for these kids. We're hoping to increase both state and federal funding for these, but really this is an area of tremendous need. Next slide. I put this slide up because when you see a child with Down syndrome, there's an automatic knowledge that this might be a child with learning disabilities, and this might be a child who has some difficulty negotiating the world in the way a typically developing child would. But kids with prenatal alcohol exposure don't have a marker. Even the face of fetal alcohol syndrome, most people don't look at that child and say, oh, I should expect some mood, some behavior challenges, some learning challenges. Next slide. So I call this an invisible disability. And, the intervention that these kids need, most children with prenatal exposures need interventions at every age, but particularly early on for child development, really looking at developmental delays, over time, looking at learning needs, particularly when language comes on board, what types of supports do kids need, looking at attention. And then I would argue, and because in my practice I have a lot of teenagers, preteens and teenagers, that they continue to need support in addition because they can be at risk for their own substance use. As I talked about before, every child has a little bit different needs, but getting diagnosed and accessing interventions is really important. But there is often a lack of services in communities for getting these services and getting services from people who have an understanding about the impacts of prenatal alcohol and drug exposure. Next slide. Why is it important to diagnose and give services to these kids? Because the research tells us that early diagnosis and intervention for children with prenatal substance exposure throughout childhood and into adulthood prevents some really important things: school failure, childhood trauma, including multiple placements in the foster care situation, as teenager and young adults, trouble with the law, increased risk of mental health problems, and again, diagnosing and intervening early and getting ongoing support can stop the perpetuation of the cycle of substance abuse. Next slide. I feel compelled always to put in a really important point in here, which is that prenatal substance exposure really has significant overlap with adversity. We do know that kids with prenatal exposures are more likely to have a history of childhood neglect and abuse. Many of them are in foster care, and because of some confusing behaviors for foster parents, can burn out of foster homes and have multiple placements, which of course adds to childhood trauma. Many of these kids have a family history of learning issues and mental health problems. We do see some of the birth parents, many of the birth parents have turned to substances as sort of self-medication for mental health issues. Next slide. And I put this in here just because, these are kids that come into our care with what I call invisible suitcases. I work a lot with foster children, and when foster children come to new home, they have a suitcase that's filled with clothing and toys, but they have a suitcase filled with invisible things: prenatal exposure, history of early childhood trauma and neglect. So again, that really important lens to know that prenatal substance exposure often has a significant overlap with adversity. Next slide. The good news is that even kids with these multiple vulnerabilities, early intervention programs for prenatally exposed infants also target the brain areas impacted by trauma. We know early childhood trauma can cause brain damage, just like prenatal exposures. But the good news is that early intervention really can support kids who've experienced trauma as well, so that they have better outcomes down the road. Next slide. So a quick summary for you from me is the number of children prenatally exposed to substances is much higher than most people think, much more common than most people think. Substances can cause brain damage, which leads to a variety of developmental problems. These kids are under-recognized and underserved in the current healthcare system. They're also at high risk, as I just talked about, for trauma. And early intervention services have a profound impact on this population's development and long-term outcomes. Thanks very much for your attendance.
Much, Dr. Bledsoe. I'll take over now. My name is Ryan Conley. I'm the director of Hope Rising Clinic, and I'm going to talk to you a little bit about what Hope Rising Clinic is and how we got started. So Hannah is also going to put up our slide deck. Get started as soon as we can. We started through Wonderland Child and Family Services. Wonderland Child and Family Services is a first-free organization. Thank you, Hannah. You can go to the next slide. That was founded in 1969. And in around 2014, King County began to require screening for substances at birth. And what surprised us at the time, which certainly doesn't now, is just how many clients we were seeing that had substance exposure. And so our mission changed a little bit. As we tried to gain information about how to best serve these kids through our Birth Screen program at Wonderland, We didn't really find a lot of resources. We found some research, some great research on alcohol exposure during pregnancy, but not much more beyond that. However, we were fortunate to find that we have at the University of Washington the Fetal Alcohol Spectrum Disorder Diagnostic and Prevention Network. And that's quite a mouthful, but that is where we met Julie, and they are one of the only places in the States that can actually diagnose, or in our state, can diagnose fetal alcohol spectrum disorder. So we got a lot of good training at UW on how to diagnose and what to expect in kids with FASD, but we were seeing a lot of other exposures, and that wasn't telling us enough about how to treat these kids. So we started to do a little bit of our own research just to find out how big of a problem is this. Diana, you can go to the next slide, please. And so the statistics honestly really kind of shocked us. And so what we found is that PSE, or prenatal substance exposure, is one of the largest under-identified and underdiagnosed causes of developmental differences in kids. It is 4 times more prevalent than autism. I like to sit with that one just for a minute, because as Dr. Bledsoe just mentioned, think about all the money that goes into autism, as it should. And that is only a quarter of the number of kids that have PSE. And so that was really eye-opening to us. And so we also learned that 80% of kids in the US foster system enter foster care, at least partially due to PSE. 80% of kids with fetal alcohol spectrum disorder are removed from the care of birth families. 70% end up getting suspended, expelled, or drop out of school. 60% become involved in the justice system, and that the life expectancy of those with FAS is about 34 years. And so what we realized is we don't have anywhere to send these kids after age 3, and we really needed to do a better job of serving this population. And so from that, Hope Rising Clinic was born. And it started in 2019, and about 3 hours later, the pandemic hit. And so we kind of had to throw our whole service model and everything we had learned up in the air for a while until we got a better handle on that. And now we have a really thriving clinic. And so from here, I'm going to turn it over to Bree Anderson Feldman, who is our therapy supervisor at Hope Rising Clinic, and we'll talk a little bit about our service model and what we do there.
Great, thanks, Ryan. Welcome, everyone. So once a family comes to our clinic, either through self-referral or referral through another agency or organization, they start and meet with our intake coordinator, who offers just a brief orientation to our clinic. And it's a way for them to really assess and make sure that the commitment they're making is one that they can do, and that our services are also a good fit for them at the time. So once they go through the orientation and the needs are determined, we go into our eval process. And our intake eval is really modeled off of what Ryan mentioned from the UW's FAS-DPN clinic. It has a transdisciplinary model. So we have a mental health provider, an occupational therapist, excuse me, and a family resource specialist, all on site to offer a really thorough and comprehensive eval. And just like Dr. Bledsoe was saying, this is a really nuanced population. And so we really want to give, from the onset, a very specific assessment to help us as clinicians really best serve this family, but also as families to, also receive the best information possible from us. So it's a two-way process there. So that takes about 3 hours. We have about 3 slots per week that we open up for evals. And then from there, we meet as a team. We review all of the assessments that were collected by the providers, and we decide which modality might be the best fit for this family to start the caregiver education program with, whether that's with the OT or the mental health provider. From there, we start, once a provider is assigned, we start the caregiver education program. And that is a really wonderful program. It is a 10 to 12 week virtual program offered to caregivers as a way to really introduce them to the sort of the what and the why behind PSE. We work through 10 to 12 different weeks, but we have about 5 modules that we work through that focus on the 5 key areas that we've identified are important for PSE. I'm going to get into that in the next slide in a little bit. So more stay tuned on that one. But from after the caregiver education program, ideally parents are starting to perceive and see their kiddos' behavior not as something that they need to fix or to change or something the kiddo can't do anything about or won't do anything about rather. But we're really looking at having a mindset shift so caregivers can start to see their behavior as something that kiddo just really can't do anything about. It's nothing inherent that they, it's not that they're choosing not to, but they just can't. They don't have the resources online enough yet to be able to make those changes. So we'd like to give lots of information in those first 10 to 12 weeks. And then we move into our therapy model in the clinic. And our clinic services, again, are really tailored to these 5 key domains of PSE. We also really value the relationship that was established with the caregiver, and we want to continue that into our clinic work. So part of our therapy program involves caregiver coaching alongside the therapy services. So our providers will meet, weekly with their clients and offer a trauma-informed approach that blends play therapy and other evidence-based approaches, that are rooted in PSE information. And we also meet monthly with caregivers. So, and sometimes caregivers might join sessions to learn some new tools and tricks to support them at home. Sometimes we're just really translating what we do in the therapy office to how they can, maybe better accommodate at home. A lot of what we're doing is supporting families to look at PSE exposures and the behaviors that kiddos have as needing better accommodations. So again, it's not about changing the kiddo as much as let's look at the environment and see what we can do to increase their success in their environment. And also to empower kiddo to speak for what they need and to maybe go towards a regulation tool that they didn't know they could have access to before. So we're really working with agency and empowerment in the model. And then from there, we usually see families for about anywhere between 2 to 4 plans of care, which is roughly about a year and a half. We move to discharge. But when families do discharge, it doesn't mean they can't come back. Of course, they can always come back and see us. And if they see us within that 6-month window, they don't have to go through the whole eval process again. So they can come back in and sort of shore up resources and then get back to their life again. So we have this nuanced approach that's really specific and tailored to PSE. And I'm going to talk a bit more in the next slide about the caregiver education program. So like I said, this is a 10-week virtual program that we started to really lay the foundation for caregivers to better understand the needs of their kiddos from the beginning. Way before we even start work in the clinic, we want the caregivers to really be on board and to better understand what we're working with here. So we start with an intro to PSE and the brain, and then we move into these 5 key areas. We talk about executive functioning, we work with sensory processing, self-regulation. We also work with attachment and take a whole module to look at, the impact of one's own parenting on their child, but also how caregiver was raised and the environment that they learned from growing up and how that might be impacting their kiddo now today. And starting to change some expectations maybe about those different parenting styles based on what they've learned from their past. We talk a lot about relationship and developing a secure attachment. And then we also, finally, we meet with our family support specialist and the family, and we talk about ways the family support specialist can offer advocacy and resources to the family, whether that's in their school systems, and we talk about IEPs and behavioral health plans. If they already have those established, they might need other resources in the community. So it's a really wonderful way to, again, start taking what we're doing here at the clinic and branching it out to the community. And also seeing how families can start to take what they've learned and bring that and advocate for their children out in the community as well. Next slide. And I just wanted to add too, with the caregiver education program, we've had really great success with it. And we've had, caregivers report that they have, I think somewhere up to 90% an increase in their bonding and attachment with their child and better understanding of what PSC really is about and how best to support their kiddo at home. So it's been a very exciting time for us at the clinic. We're making our way through the first year of that program and seeing a lot of great success. We do pre and post assessments with that as well. So we're getting some really good data. Another piece around the clinic's model, I spoke about trauma-informed services that are really woven throughout our occupational therapy, our behavioral health, into our pair coaching and our feeding support and advocacy. We also really work with our family support specialists, and we have those in our clinic, and we also have a whole nother set of providers that work in the home. So our home-based services are another aspect of Hope Rising Clinic, and our home-based services are really geared towards families who might have barriers to coming into the clinic. So whether that be lack of housing or transportation instability or employment instability, we really like to meet families where they are. And we have a mental health provider and a family support specialist that can meet them at their home or in the community to really start working to stabilize the family well enough so that they can start to come into the clinic and really work with us in the clinic setting. So we have we receive referrals from different agencies. Homeward House and Sound Pathways are two key agencies that refer folks to us for a home-based program. These home-based families are families who are in early recovery and working towards reunification with their child or children. So again, we're sort of taking a condensed version of Hope Rising Clinic and offering that to our home-based folks and supporting them to get stable enough and sort of bonded again, and working through some of those attachment disruptions so that they can come into the clinic and be ready for our clinic work and our caregiver education program. Just see, I think that's the last slide for me. I'll hand it back to Ryan.
All right, thank you, Bree. So we've talked a little bit about the work that we're doing with our families at Hope Rising Clinic, but as I was speaking in the beginning, there was a real lack of services. And so one thing Hope Rising has lobbied the state is to provide more resources and more provider training for working with kids and families with PSC. So in 2023, the state passed House Bill 1168, which did just that. It provided funding and a pathway to train more providers throughout the state on what PSC-informed services mean. And so the state has contracted with Hope Rising Clinic to provide that training. So we worked with the Washington Healthcare Authority to create a 3-day training program. And we had the first one launched earlier this year and filled up in 2 days and got 50 people on a waiting list. And we had a great 3-day session. We trained specifically Kindring Center's Cherish program. We also worked with the Muckleshoot Tribe early and special education staff, along with providers from all different sorts of organizations and school districts. And part of our model now is to not just provide services for the families we see, because Hope Rising Clinic is the only clinic in the state that works specifically with this population, and really one of only 4 or 5 around the country that do this work. And so we know, given again what we've said about this being 4 times as prevalent as autism, there's a lot of kids out there that need our services. So since we can't provide it all ourselves, we're really trying to reach out and train providers throughout the state in some of the work we do. So in addition to the trainings we've already developed, we are working with our own ESIT early support staff of Wonderland, and they're doing a 3-day training as we speak. Actually, that's going on right now. And so our plan over the next year or 2 is to develop a number of other trainings that we can take both to providers, possibly to caregivers, through the state and beyond, and training the work we do specific to working with kids with PIC. And again, really focusing again on that attachment and trauma history, executive functioning, sensory processing, and behavioral and emotional regulation are really at Hope Rising the 5 kind of key areas that we work a lot on and that we're trying to train others on. And so we are fortunate to have some of our own family ambassadors here. So Bree, I will let you introduce our next speaker.
Yes, thank you, Ryan. So I'm honored to introduce LaShawna Johnson, who's a devoted mother and teacher and advocate. She's going to speak about the power of education and support and community that she's found here at Hope Rising Clinic. So I will pass it to you, LaShawna.
Hello. So, my name is LaShawna, and I have a daughter, Treasure. She's 6 years old, and she suffers from PSC. Since we've come to Hope Rising, it's been life-changing. When I first started, of course, I had to go through the caregivers program. And in the beginning, I was like, well, I don't need that. She's the one who needs the help. I know what the problem is. No, I didn't. I thought I did. I learned so much. Just the first visit, I learned about her. I mean, she just had these issues around sensory. She was really clingy. Just all of these issues that I thought I understood, and I realized I had no understanding. So what I've gotten out of it is we have a firm foundation now to build on. I'm informed. I can advocate for her. I have a support system. I mean, I have my family, but they supported me the best they could, but they didn't even fully understand. There's a stigma behind what Treasure went through, what I put her through, and people don't want to hear that a child is a drug, has anything to do with drugs, they like to think that they outgrew it, or all of these things, which they don't outgrow it. You guys just told the story, and so just dealing with the caregiving portion, I learned about self-regulating and executive functioning, and self-regulation, just all of those things, and that I had no idea about, just teaching her to, I mean, I just knew some things just from trial and error, but to be able to know that these are they're clinical studies behind these things, and to learn how the brain is affected. And the thing that got me is how the brain grows from a stem like a flower. That is what blew my mind. Just the first clip or video. It made me understand why I needed what I was going through. And then now watching Treasure, she calls it her fun doctor. She looks forward to going every day. She's like, Miss Lily. She talks about her aunt. Every day she says something about Miss Lily. Lily is like family. It's therapy for me. It helps me so much. I'm a mother of 3, and I lost my oldest daughter. I lost her to an accidental drug overdose, And that changed my life, you know, and just to know that that treasure of being having prenatal substance exposure can turn into her being an addict one day, you know, if not guided and without this firm foundation, without her understanding what it is that she's dealing with that with, you know, from an early age, you know. We don't have to put labels so much on it, but just knowing what she's feeling and how to navigate it, you know, and for me to be able to help her through it. These are all things that I wouldn't have learned had it not been for Hope Rising, you know. She's in public school now. She's a first grader and she is brilliant, you know. She's such a wonderful little girl. And I'm not just saying it because she's mine. Everywhere she goes, there's just a light inside of her. I mean, she was born at 25 weeks. She weighed 1 pound and 14 ounces. And I didn't think either one of us would make it. We went home and she is thriving. You know, she's a miracle. And it is just, I'm so blessed to have found Hope Rising. I'm so blessed. And I can't wait to see where we end up with this. You know, I think everyone should have the opportunity to sit in on a session like this, just to, because it affects so many of us, if not directly, indirectly, you know. There's someone who knows someone, there's someone who's touched by PSE, no matter what, if it's not a neighbor, a co-worker's kid, a church member, whatever, you know, there's someone who has been affected by this, and the word needs to get out because these kids are suffering, these parents are suffering, grandparents, you know, we're suffering out here, and no one even knows how to identify what the problem is, you know. It's just, it's going unnoticed. Like you said, we're underserved. So yeah.
Thank you so much, Lashana. It's so great to hear your story, and really appreciate your time and energy. And I'm so glad Treasure's just doing so well. That's wonderful.
Thank you.
Yeah. So our next speaker is Heather Thorncock, who is a grandparent raising her granddaughter. And she's going to share a bit about how Hope Rising's parent education program has really helped her better communicate and support her family. So I'll pass it over to you, Heather.
Thank you. My name's Heather. I'm the grandmother and caregiver to my 7-year-old granddaughter, Kaya. Everyone keeps telling me how lucky she is to have me. Honestly, I'm the lucky one. In the 3 years she's been with me, we have created a strong bond, trusting that together we can do anything. Hope Rising's played a huge role in that. Only a few years ago, we were both frustrated, dysregulated, sad, and felt like we were both failures. We just couldn't connect with each other. The Hope Rising team has helped us understand her brain, her behaviors, regulate both of our emotions, communicate in ways that helped her feel safe, supported, confident, and in control of herself. Once we learned how to connect and support each other, we learned to celebrate even the smallest of victories in the biggest of ways. And it all started with the parent caregiver education, where I learned to understand how the prenatal substance exposure affected her brain, and how to respond to her with empathy and instead of frustration. They also taught me there will still be frustrating days. And trust me, there's a lot of them. But they taught me the skills to recognize and self-regulate myself and reset before it affects her. And this allows me to show up for her with patience and understanding and confidence. Kaya still has weekly sessions in the office. In these sessions, she learns more than just the skills. She learns she is gaining confidence, pride, self-awareness, and she's learning self-advocacy for herself, which is huge for her. The Hope Rising team is still here for me. As Kaya grows and changes, her challenges change too. And they're here to help me with new skills, new tools, and resources. They've helped me navigate her. They've helped me navigate her IEP, work with her teachers in her school. They've helped me. They've connected with her mental health therapist so they can build a plan together and working with her. They've assisted me in filling out very complex evaluation forms for other parts of her health care that I've needed to do. So they've never left me behind. They've always been there for me in supporting her. They've also taught me how to play with her on her level, which is something I never had when I was a kid. Because of the Hope Rising Clinic, I've learned to advocate for her brain-based disability, to recognize her and support her. I've been able to share what I've learned with our family and our friends so they understand her better, so that they can advocate for her also. And while so many of our family and friends still don't understand, I won't stop advocating and teaching them. I now have the language and the education to advocate to a world that still doesn't understand her the way I do. She's strong, she's funny, she's loving and resilient. She's wonderfully complex. The number of children with PSE in the world is greatly underestimated. There's so many caregivers out there struggling like I was, trying to understand, trying to educate, trying to advocate a disability to everyone, to their family, their friends, their peers, for something that can't be seen with the naked eye. I am deeply grateful for Hope Rising Clinic and our team, their support, their compassion, and their expertise has not only helped us build the skills that we've needed to thrive and grow together, but allowed me to become the great caregiver that she deserves. And every family deserves this type of partnership. The education through the compassion and understanding and support has made the world of difference to us. Thank you, everyone, for listening.
So much, Heather, for that. And thank you to all of our panelists. We do have some time for a Q&A now. So we got a couple that came in through the chat. So if you have one, go ahead and put that in there now. But the first that I'm seeing is asks about a lot of the children I see have both fetal alcohol syndrome or fetal alcohol effect and autism, along with other disabilities. Is the relationship between the two? I do know there was an article just this month in Psychology Today about looking at autism and if alcohol, is a strategy that could affect that. But I'm not as up to date on the research probably as our Dr. Julie Bledsoe is. So Dr. Bledsoe, do you have any information on that for us?
Well, that's a really interesting question. There certainly is an overlap in some of the things we see, some of the disabilities we see in autism as well as in fetal alcohol spectrum disorder. ADHD is common to both of those, as are things like sensory integration. But to my knowledge, there is not a paper that confirms causal, that fetal alcohol exposure causes autism. We have seen kids in our clinic where we diagnose both. They are on the autism spectrum and they have prenatal alcohol exposure. But I haven't seen it as a direct causal link yet. I think it's a really interesting question. I think the bigger question is what causes autism? Because we know there are a lot of people with autism who have no prenatal exposures, and it is a broad spectrum. So it's been a difficult area of research, but it's a great question. Thanks.
Really. We have another question regarding the 80% of children with FASD who are removed from their birth families. When are the parents' rights terminated, and how many placements into and out of parental home occurs until they become eligible for permanent placement? I'll be honest, that gets a little bit more specific and beyond my knowledge. I know in Washington State it is a imperative to try and put families back together and put kids with their birth parents when it's appropriate. I don't know if anyone, Bree, if you have some more information on how that process, what that might look like.
Yeah, could you just say the last end of that question? It just cut out for me for a minute. Just the very end of it was about reunification.
Mm-hmm. And how many placements into and out of a parental home occurs until they become eligible for permanent placement? But I guess it's, yeah.
Yeah, I mean, I think it really depends. I don't know if there's a hard, fast number for that at all, but I think it depends on many different factors. Um, so yeah, unfortunately, I don't have information on that either, but that's an interesting question to think about too. Maybe, yeah, Julie, Dr. Bledsoe, do you have?
Yeah, I don't, I mean, I do sort of working with a lot of kids in the foster care system. It is really variable. You know, the efforts at reunification, I think, are really paramount. But that also often requires, you know, a birth parent becoming capable of, you know, whether it's through recovery or medications like Suboxone, whether they can be deemed as safe to be returned to. And it also in foster care, I think the goal of understanding what prenatal exposure and prenatal alcohol exposure do to kids is really important. I think as Heather and Lashana pointed out, is for them to understand behaviors. And I think whether you're a relative or a foster parent, it's really the education about these behaviors that's crucial to preventing multiple placements in these kids. Um, your question also reminds me of a very distressing fact in that kids in our clinic who are diagnosed with full-blown fetal alcohol syndrome. So again, the most extreme example of that. By the time we diagnose them with FAS in clinic, 40% of the birth mothers are dead of alcoholism. And just a really shocking statistic, and really speaks to, you know, the need for intervention for women who are suffering with substance use disorder.
That's right. So we have another question about how does the family go about getting an evaluation at HRC and what ages do we see? So you can find us on the web. We have our intake email. It's hrcintake@wonderlandkids.org. And we'll make that available afterwards, I'm sure. We see kids up until age 13. Most kids who would come to us that are under 3 would be seen by our early support services through Wonderland. We do sometimes overlap with them, specifically when it's working with birth families in our home-based services program. They might have someone both from HRC and Wonderland or whoever their local ESIT early support agency is. If our program lasts between 1 and 2 years generally, so if a kid comes to us before their 13th birthday, we see them throughout our whole program. We wouldn't kick them out at their 13th birthday. But we are very fortunate right now, and a little bit of an aberration. We don't have much of a wait list. So it is actually a good time if you're thinking about getting your child evaluated. We don't at HRC need confirmation of alcohol or substance exposure. We do take kids with suspected exposure. We know we serve a lot of kids in adoptive and foster placements where they don't always have that information. So we're trying to throw a wide of net as possible. And then there's a question about Suboxone exposure and differences in development there. Dr. Bledsoe, could you take that for us?
Yeah, that's a great question. You know, Suboxone is a partial agonist and antagonist of opiate receptors. I mean, I think because it does have partial opiate action, there's always the potential for there to be some effect on neurobehavior in kids. But I also think that it can prevent a couple of things. We know that people who are using opiates can sometimes be using them by IV, and then the fetus may be exposed to HIV or to hepatitis C or hepatitis B. So that's an important thing. If you get people off of IV drugs, is super helpful in preventing those illnesses for babies. But I don't think there's, you know, Suboxone is relatively new in terms of it being used for the treatment of opioid use disorder. So I don't think we have those studies yet, but would be interesting to see. Thanks.
Absolutely. There's another question about what, could you be more specific about what the intake evaluation process is like? Bree, would you like to take that on?
Sure, I'd be happy to talk about that. So families would get in touch with our coordinator, and she would set up a time for you to come in on one of the 3 days that we offer during the week. It is a lengthy process, but we, 2.5 to 3 hours is what we allot for the time. We do that because we want to be as thorough as possible and to really look at the evaluation through many different angles. So once a family comes in, the caregiver meets with the mental health provider and does a caregiver interview, and the kiddo meets with the occupational therapist. Our family support specialist is sort of moving through different rooms at that point, depending on the need. They may jump in and speak a little bit about what their support could look like to the family, or they might also support kiddo during the assessment process. And then we switch. So then the mental health provider does their play-based assessment while the occupational therapist meets with the caregiver and does their interview. I should say also beforehand, the caregivers have filled out quite a lengthy amount of paperwork and assessments. So we have, for both occupational therapists and mental health providers, we have a good, robust set of data that we can use to look at where we might want to start and what area are we targeting to start services with. So from there, we come together with the caregiver, we share our results and our assessments, and then we meet kind of offline as a team the following week to talk about next steps and what might be best step moving forward. We also talk to the caregiver as well about, where they think what provider might be the best fit or what modality might be the best fit for their family to start. So yeah, hopefully that answers the general gist of it, but happy to talk more if you want to get in touch with us offline.
Great. And the last question I'm seeing has to do a little bit with what are the differences in treatments for a kid with autism versus a child with PSE. And I can start to talk about that a little bit. A lot of programs for children with autism are rooted in kind of behaviorism. So looking at your behaviors and maybe what's causing it, and rewards and consequences, and what we found is that, and there's always benefits to that, but a lot of that comes from the adults around a child determining what they think the child should be learning next and creating up a system to teach them that thing. And a lot of our kids, what we found is they may not even qualify for IEPs in schools, especially at early ages, because you're not seeing, when you get them in a one-on-one room where you're giving them a standardized test, is not at all how they actually perform in a classroom with 30 people. So they do well enough on the standardized test to get, to pass it and not get services. Then they go into their classroom and their teacher is saying, if they're a nightmare, they never follow directions, they don't sit down, they get upset all the time. And so what we will really try to work on with our kids is regulation, emotional and behavioral regulation. Well, really, in order to do that, we really need to first be looking at co-regulation and mutual regulation with a caregiver that they have a strong attachment to. And for that to happen, a caregiver has to be able to both self-regulate and know how to incorporate their child into that regulation. And often what regulates an adult is not the same as what regulates a child. So you have to kind of make all those bridges and find out how to get to point A and point B. And we're really, really trying with our kids to eventually get to the point of internal, intrinsic motivation, rather than responses to the others in their room that say, here's what I think you should be doing right now. We're trying to create, fully realized individuals and relationships and families where we work together, determine what our goals are, how do we best meet them and move forward, rather than saying, here's the person I need you to be in this classroom of 30 people. So it's a really different model, and our education system, to be perfectly honest, in my humble opinion, isn't greatly set up to achieve that goal to begin with, especially in an IEP. IEPs are often written from the perspective of what a child can't do, what's difficult for them. So let's practice that 3 hours a day, every day. Well, you can imagine if you're practicing something that you're not good at day after day in a environment that is really overwhelming to you, you start to see a lot of secondary characteristics like acting out. You might see depression, anxiety, eventually substance use, and it continues on down. So we're really trying early on to really work on attachment and mutual regulation between caregiver and child. And that's why we really focus on that relationship early on in Hope Rising. All right. Last question. I'm getting notes and I was a bit choppy, so I apologize for that. But I'm thinking it is time for us to be all done, unless you're seeing another question, Ashley or Hannah, that you want to put forth. Is prenatal exposure to fentanyl especially dangerous? I do know, like we have. Well, I'm seeing Dr. Julie have a thought already. So Julie, I'll let you take that. Is prenatal exposure to fentanyl especially dangerous? Is the question. This will be the last one.
Yeah, it's not any more dangerous than it is to opiates in terms of what it does to the developing brain. And again, opiates are probably the not nearly as damaging to the developing brain as prenatal alcohol exposure. So the effects, actually, there was a really interesting study done out of Toronto, Canada, quite a few years ago, but it looked at 25 kids with prenatal opiate exposure and followed them for 25 years. And what they found was not any significant difference in cognitive ability, but they did see a difference in kids who had experienced trauma versus not trauma in that group. They did see an increase in young adults in some mental health issues, as well as some subtle learning disabilities. But again, not nearly as damaging as alcohol.
Following up, I lied. We do have a few more minutes. Following up to that, are there parts of the brain that are implicated in both autism and PSE?
Yeah, that's a good question. And Dr. Susan Hemingway, who is the director of the Fetal Alcohol Syndrome Clinic at the University of Washington, was one of the first people to do sort of functional MRI studies in kids with prenatal exposures, and of course in specific prenatal alcohol exposure, but also other substances. And there are some differences in brain volumes in both prenatal alcohol exposure as well as in autism. The part of the brain that seems to be a little more vulnerable is this front part of the brain, that I call it sort of the secretary of the brain, is the one that helps us with organization, planning, attention. And so we certainly know that is an area that's vulnerable and keeps us on the lookout for learning disabilities, and in particular ADHD. ADHD is the most common learning disability that we see in all prenatal exposures. And again, I think it just speaks to the vulnerability of that front part of the brain.
Could you talk a little bit? There's a question about the length of our caregiver education program and the length of therapy. Could you clarify that a little bit as to our programming and how long it lasts?
Sure. And you asked the length of I couldn't hear you quite, the length of the caregiver education, length of therapy, right? That's what you said. Yeah. Okay. So the length of the caregiver education program is about 10 to 12 weeks. And it varies. Sometimes it goes longer. Sometimes we do combine of modules together, depending on how urgent the need is for the family to be seen in the clinic. But typically it's a good chunk of time, so we have enough time to really work through each of those modules, and also give homework to practice at home and come back and talk about it and really kind of start gathering more data so we have a good, robust amount of information before we move into the clinic care. And then once at the clinic, we go through different cycles of plans of care, which is basically around 5 months or so per plan of care. And a family can see us anywhere from 2 to 4 plans of care. It's roughly about a year and a half, could be up to 2 years. So it is shorter term treatment, but we really like to pack in a lot from the beginning and give as much information as we can that's digestible, of course, but also supportive so that families can start using it right away and not have to sort of get through a lengthy therapy process and wait and then learn how to apply it. We really sort of hit the ground running once we start with families. So yeah, a little bit about our timeline there. Thanks for the question.
Speaking of families, I'll put the next and I think last question to Lashana and Heather. Can you guys talk a little bit more about your successes and in the caregiver ed program and therapy moving after that, and how maybe representative you think that is of Hope Rising clients overall? Heather, why don't we start with you?
So you just how successful can a parent be? It's amazing. You know, like LaShonda said, I was wondering what was wrong with her, and I learned through this caregiver training, there's nothing wrong with her. I learned through the training, I had to learn her triggers. I had to learn how to, when a trigger happened, how to respond in a better way, in a calmer way. I learned how to, you know, bring her back before she went too far. I learned she wasn't a brat. I learned she wasn't throwing a tantrum for a reason. I learned she wasn't stealing because she wanted to break the rules, because she knew the rules. She knew stealing was wrong. It was an impulse control she couldn't control. And learning this and not shaming her and, you know, teaching her, I know this was hard. We need to put it back. I know this is a hard thing to not throw this fit. Let's calm ourselves down. Let's breathe. Let's get in our swing. These kind of things I would have gotten angry with. What are you doing? Stop screaming. Stop kicking. Stop biting yourself. Hey, it looks like we really need to take some time. How can we do this different? Do we need a moment? You know, now I sit outside her swing and I sway her back and forth. Hey, remember, we don't take things that aren't ours, you know, because these aren't her being a brat. She doesn't want to be this anyway, any more than anybody else around her wants her to do this. These aren't things she can control. There's nothing wrong with her. I learned myself that is how we interact with her. How can I keep her triggers low so she doesn't have to go through this? And that's, you know, I was like 15 weeks of training. What? By the first week, just like LaShonda said, I said, I want more. I want everybody to have to do this because it made me such a much better parent. And it's made Kaya trust me. A child who has no trust of anybody. She trusts me. And so now our fits and our meltdowns and our dysregulated moments are so far and few in between. And when they are, she runs to me for them. And that's how it's made me a better parent.
Yeah, that's so great. Lashana, I'm going to give you the last word. What are your successes?
So with Treasure, it's like she said, it's that trust that she knows she can trust me now. She can trust me with her emotions. She can trust me to advocate for her. She can trust me. I mean, before it was like I was just at my wits' end with the breakdowns, with the brattiness, and I thought that she was a brat, but really it wasn't. It was my approach. She wasn't the problem, it was my approach. And so now, like you said, let's take a deep breath. Let's take a step back. Come here. Do you need a hug? She likes hugs. And before, when she would ask for a hug in the middle of getting in trouble, I thought she was trying to wiggle her way out of it. No, she just needs that comforts her, that brings her back, that grounds her. You know, that's her self-regulation. I mean, it's a wonderful thing. Yes. So I've learned a lot. I've learned how to I've learned how to teach her how to self-regulate. And I've learned how to regulate myself also all through this program. So I think anyone who goes through it will be just as successful if they take it seriously. And they just with the first class, you'll be stuck. Yes.
All right. Well, on that note, I really want to thank everyone. I want to thank all of our panelists, especially our parents, our caregivers. You guys mean the most to us, so we're so happy to have you here. Thank you guys for speaking about Hope Rising. If what you heard interests you today, we are having a gathering and beginning of this conversation in Edmonds on the 12th for our Season of Wonder celebration. So you can find out more about that. And thank you guys for coming out and learning more and supporting us. Great to have you, and I hope you all have a great day. Thanks so much.
Thank you. Bye-bye.